Let's go to our small pediatric ophthalmic problems necessitating interventions during infancy. Quite often we see a lot of patients coming to us. Let me ask Dr. Meena to my co-chair to come over to the stage, please, and Dr. Suma. Quite often we come across patients, children babies being brought to us with complaints of opacification, some white discoloration of the eye, not looking at looking at the mother. So whether to intervene before infancy, during infancy, before 1 year of age, that's what we want to discuss during this small session. Over to Dr. Saumya for the first. Is my child seeing? Dr. Saumya Nambiar, she is our consultant pediatric ophthalmologist at Comtrust Eye Hospital. She has been in Talasheri Comtrust Eye Hospital for some time. Now she is in Calicut. Over to Dr. Saumya.
Thank you, ma'am. First of all, I would like to thank Laila ma'am and KSOS for having given me this opportunity. So vision, we know that it requires a lot of processing, lot of attention, especially when it is a chaos like this. You need to have a lot of clarity into what you're seeing. So let's compare these two infants. So you can see in the first case, the child is using both his hands. It's a 6-month-old child, and see how nicely the child is taking up the toy, tries to feel it with her mouth and looking at the toys when it is brought closer. The same way in the lower down, you can see how the child, you have shown an illuminated toy. It tends to attract the child, but you can see the child is showing some attention and suddenly zip off. The child loses the attention. Okay, it's almost the same age child. So what's happening here? So this is what we day in and day out as pediatric ophthalmologists see, especially in infants. They are crying and we are crying in our mind, what's happening? Is my child seeing? The common causes what we have to think about is congenital globe anomalies, cataracts, corneal opacities, retinal dystrophies, glaucoma, amblyopia. This is what our session is going to deal with. And today, what I am going to deal with is the abnormality of the higher visual pathways. So basically what happens in this? This is what we all know is cerebral visual impairment. Okay. So what we deal with, we all have seen adults coming with cerebral visual impairment. But the same thing, does it imply to the infants as well? So this cerebral visual impairment is a major cause of profound visual impairment in children aged less than 3 years. This is a study done in Tertiary Eye Care Center in South India. And their data tells that cerebral visual impairment and optic neuropathy have become the most common cause of visual impairment in children. So what is CVI? So basically it is a verifiable visual dysfunction. What I mean by that is when you see the visual acuity of this child or visual dysfunction, when you measure the vision, it varies from time to time. It varies from place to place. You test the child in a different environment, you may get a different finding. Okay. And why does this happen? It happens because of the damage to the retrogeniculate pathway. So you cannot attribute all of these visual dysfunction that the child has to only the anterior visual pathway. That is when the bells has to ring that probably there's something else wrong. And usually they tend to be associated with other neurological conditions like cerebral palsy. So why is it important, especially in infants? And early identification is very much necessary because the neuroplasticity occurs maximum in the first 3 years of life, and any response to the intervention is at most in this period. So we know that the front of the brain thinks, the middle feels and moves, and the back sees. Right? So you all know all this with the usual cerebral visual impairment thing, how our vision processes. That is, whatever we see goes to the occipital cortex, goes through 2 streams. One is the dorsal stream, which is the where system, which tells us or helps us understand where things are, and that goes through the posterior parietal lobe. The other one is the ventral stream, which is called as a Watt system, and that is through the temporal lobe. Now, is the CVI gaining importance? Yes. CVI, as I told, is the leading cause of visual impairment. It is leading because there is increasing incidence, there is increasing awareness, more surviving premature babies, and better neonatal care coming up. So the most common causes of cerebral visual impairment is hypoxic ischemic encephalopathy, which is found to be most common cause. Other than that, you can see hypoglycemia, seizures, stroke, metabolic disease, infection, all this can cause. And that is when your history becomes important. You need to take the history from the parents regarding all these conditions. This is just the pathophysiology which I have shown in HIE, that is hypoxic ischemic encephalopathy. You can see those gliosis that is present around the periventricular region. That is called as PVL, periventricular leukomalacia. So how do you identify these cases? So that is where we have to think, because less than 1 year, it's very difficult to identify the children. So this is where Leah in her book has told, watch out for these 5 things in the first 3 years. So you can see that here the child is an 8-week child. See how the child is mimicking the facial expression of the parent. Okay. So whenever you see a child who has a delay in development of eye contact by 8 weeks, think of CVI. Whenever you see a child who has a delay in developing social smile by 3rd month, think of CVI. Same way, a delay in awareness of hands and hand regard by 3rd month, think of this. There will be a delay in goal-directed hand-arm movement for reaching and grasping. You can see the child is learning how to do the orientation of the balls, colorful balls. So by 5 to 6 months, if this doesn't develop, you have to think. There is a delay in recognition of facial features by 7 to 10 months, think of CVI. So how do you assess? So in CVI, for adult CVI or for the elderly age group, pediatric age group, we do have a CVI questionnaire. But for infants also, we do have what is called as the pre-visual assessment questionnaire. Okay, so you can see here that this is a very crowded slide, but there are 30 questions. You can see each question will help in assessing what is the visual acuity of the child, what is the visual motor coordination of the child, where the visual processing is affected, that is VP. So each of these questions will help to get an idea of what is there. And remember, you have to differentiate between what is ocular visual impairment and cerebral visual impairment. Both can coexist. So how do you start assessing? Always check the functional visual acuity of the child. Then look for the refractive state. A high refractive state should never be missed. Do an anterior segment examination, do a fundoscopy, do a visual field assessment. So as I told, the functional visual assessment, as you can see, here what we use is called as the Leah paddles. You can see the gratings which are present on the paddles. Okay, so the child will respond to the gratings. So it will help. How does that help? It helps us in assessing at what distance the child is able to see. At what distance you need to train the child. Okay, so this is what it helps. So you can see here, the child is responding to the illuminated toys. So you can train the child with that. You can use this illuminated toys to train the child. Here you can see when you shine the bright light, whether the child is blinking or not. So it's a blink reflex that is present. So there is some amount of vision that is present. Another way you can quantify is what is called as a teleacuity. See here you can see the child is uniocularly patched and then you're testing. Okay. You can use a contrast sensitivity. So as you can see, these facial expressions help us in seeing how much the child can see your facial expressions. If the child is not able to see or has a low contrast, you can tell the parents or mother to use makeup or enhance the contrast of the face. So always look out for these visual behaviors. So as you can see in this child, you can see that there is a delay. What can you see? There is a delay in the child seeing the toys. In this case, if you can see, as the size of the beads are going, you can see that the child has difficulty. Okay, and the child is not using the pincer grasp, he is using the whole of the palm to take up the bead. See, as the size of the bead is reducing, the child is going front to see the, to take the bead. This is what you call it as the visual guided race. So just carefully look at the photo. As you get the toy, just there will be a sudden tilt of the head, see, and then the child takes up. So therefore, as I told, early intervention is very important. And this is how we do. We have to train, that is do visual stimulation, do environmental modifications and visual training. Start off with your glass correction first and do these modifications in the environment that you can do. And always teach them to use other senses like touch and hear. Okay. And always watch out for these red flags for CVI. So basically it's a teamwork and you have to include a pediatric neurologist and other speech therapists also into your training period. Thank you, one and all.
Thank you, Soumya, for that wonderful talk. Our next speaker is Dr. Suma Unnikrishnan. Suma is a professor at Pariyara Medical College. She is well known in pediatric ophthalmology scenario, and she will be speaking on. She will be speaking on the premature baby and the eye. Over to you, Suma.
Okay. So, thank you, KSOS and Laila Madam, for the opportunity. The preterm babies and the premature birth and low birth weight babies are surviving at a higher rate because of improvement in the NICU services globally. So, in India, around 3.5 million children are born preterm every year, and it accounts for 30% of ROP in India. It's a very huge number. That is the importance of this topic. Now, there are some special ocular features for preterm babies. They appear as having pseudoproptosis due to shallow orbit. The axial length will be small, as well as the size of the cornea is small. Power of cornea and lens will be more. And studies have shown that there will be increase in the cup disc ratio of preterm babies, as well as AV ratio is reduced. So when you consider a preterm baby, the first thing to be ruled out is ROP. You know, as early as 16 weeks of gestation, the retinal vasculature starts developing from the mesenchyme, protruding from the optic disc, and it will be completed nasally by 36 weeks of gestation, and by temporally by 40 weeks of gestation. So you all know how to screen this ROP, the various zones and the stages of ROP. I'm not going to the details of these ROP stages and all. And this aggressive ROP should be treated as early as possible, very aggressively. And the gold standard treatment of ROP is laser treatment. And also you can use this anti-VEGF. Now, who needs this ophthalmic screening is gestational age of less than 34 weeks or birth weight of less than 2000 gram. And even larger babies with the high risk factors like oxygen support, sepsis and cardiopulmonary problems, as well as blood transfusion, also need a screening. And as per the pediatrician's discretion, you do ophthalmic screening. So the first examination should be 31 weeks of post-menstrual age or 4 weeks after birth, whichever is earlier, and repeat it weekly or bi-weekly until the retina is fully vascularized as per the guidelines. But always the documentation is very critical. And this is a case of a baby with a gestational age of 34 weeks and birth weight of 2.2 kilogram with a respiratory distress. So we did a screening at 38 weeks. And normal vascularization was in zone 3 in both eyes. But she came 2 weeks back at the age of 6 months. There is no refractive error, no strabismus. She is perfectly normal with a normal visual development. On the other hand, this baby, he had a birth weight of 1.2 kilogram and a gestational age of 34 plus 2 days. And there was no ROP, fully mature retina at 40 weeks. But at the age of 3 years, he came with an alternate exotropia with a V pattern. So why you follow up this patient, there's a higher risk of visual impairment in preterm babies because of immature retina, optic nerve and brain, and ocular morbidity is lifelong, and they need a structured ophthalmic follow-up, and ROP is a cause of preventable blindness. So what do you look for is the child developing normally? Does the child seem to have normal vision? And does the retina looks normal or healthy? Is there any significant refractive error? Is there any strabismus or nystagmus? Are there any other eye problems like cataract or glaucoma? So what routine workup to be done are visual acuity assessment, axial length measurement, refraction under cycloplegia, dilated fundus examination, and look for ocular alignment and eye movements and measure the intraocular pressure. So as the previous speaker told about the visual development milestones, you have to observe whether the milestones are normal or not, as seen in this picture. So the follow-up depends on whether the preterm baby had ROP, whether it is treated with laser or it was a mild ROP, not treated with a laser treatment. So you can see that in this chart, if there is no ROP, there is a low risk of myopia, and the timing of first examination should be at least at 2 years of age and then annually thereafter. If there is ROP but no laser treatment was needed, then there is a moderate risk of myopia, astigmatism and strabismus, and the timing of first examination should be at least at 1 year of age and then annually thereafter. If there is ROP treated with laser, then comes the high risk of high myopia, astigmatism, strabismus, CVA and anisometropia. So at 3 months of age, you have to see the patient, and every 3 to 4 years till 2 years of age, and after that every 6 months till 6 years of age, and annually thereafter. So this graph shows that there is a low risk of myopia if there is no ROP. In mild ROP, you get a moderate risk, and high risk when there is ROP treated with a laser. So studies have shown that low birth weight interrupts with the emmetropization and increases the prevalence of refractive error. So preterm children are reported to have increased incidence of visual impairment because of perinatal lesions in the brain. So we have done a study on association of refractive status with birth weight and gestational age, a comparative study with term and preterm, and it was shown that there is a significant correlation between birth weight and refractive status, and the incidence of myopia was found to be inversely proportional to the birth weight, and anisometropia was seen more in preterm with statistical significance. So you have to rule out amblyopia as a result of anisometropia, astigmatism following ROP treatment, and you have to manage it accordingly. And strabismus is less common than refractive error in preterm babies, but patients with cerebral palsy it is more common. The degree of misalignment can vary over time. So making the decision whether and when to operate are more difficult than in a children born at term. So CVA should be suspected if parents report that their child does not seem to see normally in the absence of any other obvious ocular disease. You have to rule out cataract and glaucoma following treatment for ROP. Now, in nutshell, the long-term sequelae are myopia, astigmatism, strabismus, amblyopia, nystagmus, CVA, and late retinal detachment. So, this baby, 28-week preterm, by screen for ROP detected at 5 weeks, and timely laser was given. Now, at the age of 5-year-old, she is wearing glasses and going to school as a normal baby. So that emphasizes the importance of early detection. But on the other hand, this girl lost her vision in the right eye because of stage 5 ROP, but in the left eye, she maintained the vision of 660 after vitrectomy for stage 4 ROP and after cataract surgery. So you have to counsel and educate the parents about importance of follow-up, highlight the risk of visual impairment, and send follow-up reminders and return follow-up cards. And reviews should be linked with the immunization days, and encourage compliance with spectacles and amblyopia therapy, and reassure them that about preventability with the timely care. So there are 3 major programs in India: RBSK, NPCB, visual impairment, and HM to treat this, to manage this childhood blindness. So to conclude, preterm infants are high risk of eye problems, and ROP is eye threatening, but it is preventable. A structured screening and follow-up is essential even after the completion of ROP treatment. So early detection will better vision, better life. Children who are irreversibly visually impaired or blind should be referred to vision rehabilitation at the earliest. Thank you for your patient hearing.
Thank you, Dr. Suma, for being with us in spite of your illness. I know you are not okay. So over to Dr. Meena CK. She is the senior consultant pediatric ophthalmologist at Little Flower Hospital, Angamali. So evaluation of the white pupil, is it cataract? Should the child be seen immediately? Is there any urgency? Over to Dr. Meena.
Good afternoon, everyone, and thank you, Laila Madam and KSOS organizers for this opportunity. I'll be speaking on evaluation of white pupil and to find out whether it is cataract, because cataract is the most common problem that we see in a white pupil. So, talking about white pupil or a leukocoria, it is an abnormal reflex coming from the pupil. It can start from the pupillary plane to the retina. So the lesion can be anywhere there. So this is one assessment that you have to do in an infant. If you don't do anything else, if you can just do your red glow testing, that's more than enough. So what is the ideal situation? So ideal situation is a proper normal red glow from both the eyes, which has to be almost comparable, and this itself can make you rest assured that there is nothing great, much significant in the visual axis. Now coming to the various factors or various pathologies that can produce a white glow in the pupillary area are so as I mentioned, how can you assess the level? So it can be something from the pupillary plane to the retina. So ideally you should be able to do a proper slit lamp examination, either with a handheld slit lamp if the child is very small, or the usual slit lamp examination, which itself will give you a clue as to the position of this white glow. So it has to be a Bruckner's test and a slit lamp examination, which is a must. So let's go to various conditions which can cause a white reflex. This is not a white reflex, you can call it a brown reflex. Actually, this is at the pupillary plane, and this is a very aggressive persistent pupillary membrane. It may not cause that much of diminished vision because the child might see through a small area, but you can have a compensatory growth of the eye with very high myopia and associated amblyopia. So whenever there is a persistent pupillary membrane which is very aggressive, it is ideally you should be treating it, just removing it without injuring the lens capsule. Now coming to the most common things, common one that we see as a white glow, the commonest that we see are the cataracts. So cataracts like this is a total cataract in a child, which is not difficult to assess. Even then you need a proper slit lamp examination to see the amount of cortical involvement, capsular involvement, etc. If possible, it's ideal way to see the level of opacity. And these are the ones you might miss, especially they can be unilateral, like this is a typical posterior polar cataract, which you might miss if you don't do a red glow test properly. So in such cases, even though it is a small one in the center, it may need treatment because it causes severe amblyopia. And yet again, these conditions, unilateral, you can see the typical PHPV. It's an anterior PHPV with the fishtailing like posteriorly. You can see that stump of the PHPV and the central cataract, and all these can show as a white glow in the pupillary axis. Now coming to this condition, like again came as a white, referred as cataract, but you can see there is some amount of difference in the cataract. The corneal diameter is little on the lower side, not that bad, and you can see that fibrosed capsule, and on slit lamp we could make out that it is not just a typical cataract, and difficult to remove the capsule. You have fibrosed capsule and it's being excised. And definitely there is cataract, but in such cases, unilateral cases, you have to suspect something posteriorly. Obviously, we will do a B scan in all cases, but it may not be evident in all the B scans in children. And there is a cortical cataract here, but once the cataract is removed, you can see the typical feature of, this is a dangerous looking PHPV. It is a PHPV, it is an anterior PHPV which looks like which has got a vasculature like that of a retina. So it is ideally, it would be better for the anterior segment surgeon not to touch it, because there can be folds of retina involved in this. So I stopped the surgery with this, and obviously it was an anterior PHPV with a fold of retina in it, and we got the help of the retinal surgeon for the central excision of this area, which can be quite vascular too. So once we go out of the lens plane, it's actually not your territory, but still you can make your diagnosis. Like in infancy, the next thing that you can see is an absorbing vitreous hemorrhage. Many a times the child get referred to you as ROP, but you have to see them properly. And vitreous hemorrhage is not that rare, especially if they have had a traumatic labor. You can have vitreous hemorrhage, and in the absorbing stage, it can present as a white glow. So it may be difficult to see the posterior vasculature in such cases, but you have to do a B scan, and serial examination is extremely important to be sure that the underlying retina is okay. So vitreous hemorrhage is yet another condition that you see. And next is a coloboma, which is actually a congenital one. So such cases, when involving the macula and the disc, the results are usually not that good, and they come with a red glow, and there can be associated anterior segment associations also, like an iris coloboma. Now this is something that you don't want to see, that is retinopathy of prematurity of stages 4 or 5, which is an offense. Actually, we shouldn't be seeing cases like this, but still we do see sometimes with patients referred to us at 3 or 4 months of age, a premature born, and the excuse would be like they couldn't do an examination because the child was very sick in the NICU, so a proper examination was not done, or maybe there was a sudden progression in between, the child was sick, and it was obviously they wouldn't be able to examine the child properly. So this is something that should never happen, because extremely difficult to treat and the results could be difficult. Now coming to other conditions like toxocara uveitis, when it is involving the posterior pole, you can have granulomas, which can also present as a white glow. And Coats disease, it may not be there in infancy, but because of the subretinal exudates and the retinal vascular changes, all these goes into the posterior segment surgeon's territory, but still you can make a diagnosis when the patient comes with this particular complaints. And familial exudative vitreoretinopathy is yet another condition where the white glow may not be that significant depending upon the grades. And this also, again, you need a posterior segment help for all this. So this is a child who presented to us 2 weeks back. With the parents were noticing a white glow since about, they say, 4 months, when photographs were being taken unilaterally, and they were no squint, nothing, and they brought the child, and this is the by the time the child reached us, this you can see the typical retinoblastoma with all the vitreous seedings. All these are features that you feel so bad to explain to the patient. Patient was not referred as cataract, but these are the situations where you find it very difficult to explain to the parents as to the grave conditions that they have to face. So like pupillary plane and crystalline lens level white glows are more amenable to treatment. As you go posteriorly, it's little difficult, and the vision threat is more as the level of white glow recedes posteriorly, and any abnormal pupillary glow warrants immediate attention. Thank you.
Thank you, Dr. Meena, for that informative talk. Now I call upon Dr. Laila Mohan Madam for her next talk on evaluating the cloudy cornea. Laila Madam doesn't need any introduction. She is the Chief Consultant of Pediatric Ophthalmology at Comtrust Eye Hospital, Kozhikode. Over to you, Madam.
Thank you, Dr. Suma. So, evaluation of a child with cloudy cornea. This is not an uncommon situation, the child being brought with either bilateral or unilateral white eye or opacification of the cornea. So, cloudy cornea is a challenging situation. We need to look for glaucoma, lens, whether it is cataractus, retinal pathology, optic nerve, the health of the nerve. Corneal opacity as well as cataract also can coexist in rubella and in many other conditions. So, multidisciplinary approach with cornea, glaucoma specialist, pediatric ophthalmologist and geneticist whenever possible should be there. And imaging the anterior segment gives clarity of what underlies the cloudy cornea. And urgent Surgical intervention may be necessary in situations if it is glaucoma diagnosis is made. The old mnemonic stumped sclerocornea, tears, ulcers, mucopolysaccharidosis, Peter's edema, like in glaucoma and CHED, does not specify the underlying pathology. So now this is no more followed. The newer classification by Dr. Kenneshal is that primary corneal disease is specifically corneal, like in corneal dystrophy, cornea plana, structural pathology like dermoids, and CYP1B1 abnormality, and secondary developmental corneal disease where there is an anterior segment developmental abnormality like anterior segment dysgenesis. It can be either iridocorneal or just iridotrabecular as in primary congenital glaucoma and aniridia, and the secondary acquired ones like mucopolysaccharidosis infective as in rubella. It can be there at birth also if the child acquired infection in utero, and trauma and non-infective cases. So the primary corneal disease like endothelial or CHED, which is the commonest. It is not so very common in our part. It is a rare condition. And posterior polymorphous dystrophy, corneal stromal dystrophy, endothelial dystrophy, many of them are have a better prognosis with keratoplasty, but the timing of surgery is again debatable considering the high rate of graft rejection and surgical challenges due to the low scleral rigidity, positive pressure and shallow AC in the neonate. And so the risk of amblyopia and nystagmus is also there when surgery is delayed. So all these have to be considered when taking up for surgery. So endothelial keratoplasty is the newer method in endothelial disease. So CHED is another a condition which has to be differentiated from congenital glaucoma. It is rare. Consanguinity may be there and may present at birth or little later. Bilateral symmetrical blue-gray ground glass appearance from limbus to limbus opacification and with sometimes localized spots due to localized edema, and retroillumination if the cornea is the opacity is not so dense can show the beaten copper appearance of the thickened decimates, and IOP may be falsely high also. So the other features have to be taken up for differentiating. Pachymetry is very high. It may be 2 to 3 times the normal. Corneal diameter is normal. No, the child doesn't present with the watering or photophobia or blepharospasm. So these are the features which might differentiate it from glaucoma. So keratoplasty is the way to go in these cases, and in congenital cloudy cornea secondary to anterior segment dysgenesis, they present with a wide vast phenotypic and genetic heterogeneity. Axenfeld, Rieger, Peters is the commoner one. Genetic analysis may be done if it is possible and affordable, and UBM or OCT will show the defect. UBM can be done under GA. OCT handheld is not available so freely, so sometimes it is difficult to assess the pathology under the corneal opacity. So often in Peters presents with the central corneal opacity with a little eccentricity, so sometimes we can do away with an optical iridectomy considering the challenges in PKP. So UBM findings in Peters will show whether there is an iridocorneal only or lenticular pathology as well. These are the 3 conditions which need to be differentiated at birth. The CHED, that is congenital hereditary endothelial dystrophy, Peters and primary congenital glaucoma. So CCT is very, very high, 2 to 3 times in CHED. Corneal diameter is high in congenital glaucoma. In Peters it may be smaller or normal. And iris thickness is normal in CHED. It is thin in Peters and congenital glaucoma. Hyperreflectivity can be seen in CHED. And in Peters, you can see the adhesions between the iris and cornea, or sometimes even the lens may be adherent to the cornea. And the pattern of opacity, limbus to limbus corneal opacity in CHED. And the age of onset, sometimes it is at birth or sometimes a little later in CHED. So if we have the privilege of genetic study, then we know that SLC4A11 is CHED for 100%, we can make sure. Peters and PCG congenital glaucoma, it may not, majority may show CIP P1B1 genetic pathology. So evaluation and detailed history is important. EUA may have to be done, and B scan will show any posterior segment pathology, and a cupping also can be sometimes made out in advanced cases. UBM gives good images of anterior segment in a clouded cornea, and linear ultrasound scan, which the anesthetists use for vein detector, can be used for assessing the anterior segment, because the handheld OCT may not be available. It is not usually very commonly available. And torch titer has to be done to rule out any infective pathology, and systemic associations may have to be ruled out. And laryngeal mask anesthesia is better, not ketamine anesthesia for an EUA. IOP may be high in falsely high. IOP better checked with Perkins. Slit lamp, gonioscopy, axial length, fundus for cupping, all these have to be checked, and a cyclorefraction definitely. Cloudy cornea with Habs ray, this is a child with already a tube there for EUA. You can see the double contoured breaks in DM. The picture on the right side is a tear during birth due to forceps of delivery. Congenital glaucoma with iridocorneal additions and partial aniridia, all these have to be followed up for increase in IOP. And a flying baby OCT as can be taken sometimes. It's not always possible. We can try. So primary congenital glaucoma has to be suspected when the corneal diameter is higher. For his age, at birth it is usually 9.5 to 10.5. If it is higher, you have to suspect. More than 12 millimeter under 1 year is definitely suspicious, and more than 13 millimeter at any age is highly suspicious. The axial length also has to be measured and followed up. A serial measurement whenever there is a doubt gives you a better idea. And cupping, any asymmetry between the cup, usually there is no cup in a child. So just want to say, this child was brought with bilateral opacity, UA was done, and during every case we do a scan to note the axial length. So when A scan was being done, we didn't see the lens spike. So UBM, again after that, this is the lower figure shows the lens spike. So we did a B scan and found that there is no lens there at all. It is a primary congenital aphakia, which is a very rare situation, but a very bad severe developmental anomaly. Vitreous is abnormal. Keratoplasty often produces very poor outcome with iris bulbi. So in these cases, imaging is very important to know whether the lens is there at all. And this child came with a white eye one fine morning with an acute eye drops. He had glaucoma. Glaucoma surgery was done in one eye, and later he came with the haziness and IOP high in the other eye also. Both eyes were operated. This Peters, we did B scan and found that there is no anterior segment pathology behind the cornea, but for a thinning of the cornea. So an optical iridectomy was done, and later refractive correction and patching. And I'm happy she has 612 vision, 618 vision at 12 years of age with occasional divergence. Probably we might do a surgical correction for squinting later. So corneal dermoids are purely corneal. We can see them. An OCT may show they can be operated for lamellar or penetrating keratoplasty can be done. So it's important to diagnose a glaucoma and follow them up with serial axial length measurements. Not all opacities are to be labeled as sclerocornea because we need to know what is happening underneath. And surgical intervention when it is diagnosed is urgent. So the risk versus benefits of corneal transplant has to be considered and outweighed when considering surgery, and discussed with the patient's parents whenever we consider surgery. Thank you.
Thank you, madam, for that wonderful talk. And it's always very difficult to distinguish between corneal dystrophies and glaucomas, and also your treatment also varies according to that. The next speaker is Dr. Indu B. Narayanan. She'll be speaking on evaluating the watery eye with congenital dacryocystitis. She is an oculoplasty surgeon. She was with us in LF for a while and now at Comtrest, Talisheri and Calicut Comtrest. Okay.
Good afternoon, everyone. I thank Laila ma'am and KSOS for giving me this opportunity. So I have been interested with the topic evaluating the watery eye. So to begin with, it is very important to understand the anatomy of the lacrimal drainage system. It starts directly with the puncta, the canalicularis, and there is a common canalicularis, continues as a sac, and inferiorly it progresses as the NLD. So there is two valves which are important. This is the valve of Rosenmuller, and in the inferiorly there is the valve of Hasner, and it opens at the inferior meatus. So a block anywhere along the drainage system can cause epiphora. The most common cause of epiphora in children is of course NLDO, or congenital nasolacrimal duct obstruction. But it is very important to rule out all other causes, like look for the lid malpositions if they have the epiblepharon or congenital entropion, or any lash abnormalities like trichiasis. Always have a look at the puncta, whether there is any punctal agenesis or stenosis. And it's also very important to understand the embryogenesis. So a few words. Here it starts with an ectodermal thickening to form the lacrimal cord. The lacrimal cord canalizes, and it is very important to understand that the distal site, that is a valve of Hasner, is the last to canalize. So in around 60 to 70% it is imperforate at birth. So this imperforation, it clears by first month of life in about 95% of the cases, and 96% by 1 year. That is why the age of 1 year is very important. I would like to bring to this diagram. Here you have the inferior, this is the inferior turbinate, and this is the floor. So the usual NLD, it opens into the inferior meatus. So here are the variations in NLD. Here in the picture, it is opening in the vault of the inferior meatus. NLD, here it is coming down and opening in the floor, and the NLD is impacted on the inferior turbinate. Here it is on the anterior aspect of the inferior turbinate. It is blindly ending into the maxillary sinus, and here there is no NLD. So what happens is that all this causes congenital nasolacrimal duct obstruction, and this is called as complex CNLDO. Now clinical features: the child presents with watering, discharge and matting of the lashes, and it usually worsens with the URTI. So it can also present as cystic swelling below the medial candle tendon, which is called as a dacrocystocele, and also as lacrimal fistula. So a few, just a word about the dacrocystocele. When it causes, when there is, along with the NLD, when there is a functional obstruction of the valve of Rosenmuller, it causes the dilatation of the sac, and that is dacrocystocele. And this, along with the dilatation of the distal part of the nasolacrimal duct, it causes intranasal cyst, which is seen in the endoscopy like this. So this causes respiratory insufficiency in infants because they are nasal breathers, and in a bilateral case, obviously it is a life-threatening condition. So examination, unlike in adults, it's very difficult because you can't do a syringing. So basically there is an increase in the tear height, and fluorescent test is dye disappearance test is positive, and always look for ROPLAS. So these are the syndromes associated and the abnormalities associated. So the treatment, until 1 year of age, you need not do anything. Basically conservative treatment, not anything, but you have to ask them for lacrimal sac massage or compression. In case of purulent discharge, topical antibiotics are prescribed. So the idea is that it increases the intraluminar pressure and to rupture the valve of Hasner. So the technique, it's very important. Always instruct the bystander, I mean the parents, how the technique is. Okay, and it's very important to know that they have studied it properly and they are doing it in the correct way. So you always use the index finger and just inside the anterior lacrimal crust below the medial candle tendon, and it can be done about 10 times a session, 4 times a day. So once it is 1 year of age, still the child is having watering, what is next? It's probing. So probing, it's recommended under general anesthesia because it's more controlled probing, and you can evaluate the lacrimal system. Also, endoscopic evaluation as well as the treatment of nasal pathology is also possible. So now about the technique of probing: decongest the nasal mucosa and use the punctum dilator. Punctum is dilated. The probe is introduced just with a stretch on the lower lid or the upper lid, whichever. And the probe is directed now in the horizontal direction and until you get the heart stop. So when heart stop is reached, just withdraw by 1 millimeter and then gently direct it vertically and direct it along the direction of the NLD, that is lateral, inferior, lateral and posterior, until you get a gentle soft stop, this giveaway feeling is obtained. So, and also look at the endoscopy and see that your probe is correctly, it is visualized under the inferior turbinate in the inferior meatus. So why endoscopic assisted probing? Because it gives a direct visualization of probe and avoids the false passage. And also that you can diagnose the NLD variations and also treat the intranasal abnormalities if any. So even after probing, if there is a recurrence of symptoms, it's called as a failed probing or persistent CNLDO. So this occurs mainly in complex CNLDOs or associated proximal obstructions or in a case of dilated or atonic sac. So what next? You can repeat the probing or a probing with silicone intubation. So this is a 56% is what the literature says, the success rate of repeat probing, and 84% if it's along with the silicone intubation. So when is a DCR indicated? If it's a multiple failed probing or if it's a case of complex CNLDO or a bony obstruction. If you're feeling the bony obstruction at the time of probing or you get an atonic sac, you can directly convert into a DCR. So the age of DCR recommended is about 4 to 5 years because for the pneumatization of the sinus and the maturation of the bones. But early DCR is even reported many times in some case series, even at the age of around 8 months. So just a slide on the dacrocystocele management. It's basically conservative by sac compression, but if it is associated with an intranasal cyst, marsupialization is required. And lacrimal fistula, it usually spontaneously closes after the closure of NLD. After the NLD resolves. And if not, fistulectomy can be done. So my take-home message is that always check on the parent's technique of sac compression. They may not be doing the correcting, and have an idea about the complex CNLDO, and endoscopic assisted probing is thus recommended. So I would also like to invite for our National Conference of Oculoplasty. Next year it's conducted in Kochi and the month of April 24, 25 and 26. So I would like to invite you all for the same. Thank you.
Thank you, Dr. Indu, for that brisk talk on the watery eyes. So would you do endoscopy in every infant for probing? Okay. Over to Dr. Ruhi. She is the consultant pediatric ophthalmologist in Comtrust Eye Hospital. She was there in Talasheri as well. Now in Calicut. Over to Dr. Ruhi for evaluation and management of crossed eyes in an infant.
A very warm good afternoon to everyone. I thank Dr. Leila Madam and KSOS for this beautiful opportunity. Today I'd like to discuss how to evaluate and manage cross-eyed infants. This is purely from the point of view of a general ophthalmologist. If a cross-eyed infant comes to your clinic, how do you evaluate and when to refer them? Let us take the case of this little cute baby, Sarah. She was 4 months old when she presented to us, and since 2 months of age, she had been squinting, according to her mother. 3 eye specialists told her to wait and watch. She still came for another opinion to us. So the question is, when to wait and watch? What is infantile esotropia? It typically presents from birth to 6 months of age. The angle is more than or equal of 230 prism diopters, usually stable and constant. It is usually non-accommodative. Cross fixation is common initially. Optokinetic asymmetry can also be seen. Limited abduction, latent nystagmus, and DVD, which may develop later. The accommodative trap, do not miss this. Look at this 7-month-old baby with 35 prism diopters esotropia at near and distance. With +5 diopter glasses, she was orthotropic at all distances. So the important thing is always do a cycloplegic refraction. The parallel war that we are waging is amblyopia. Why do we need to treat amblyopia before surgery? Shorter treatment duration if started early. Better surgical outcomes. There is a possibility of loss to follow-up after surgery. If we wait till after surgery to start patching, there is a possibility that there will be loss to follow-up. The goal when we are patching is alternating fixation or to hold fixation through the blink. The red flags not to be missed. First, neurological, developmental delay, seizures, poor visual responses, acquired onset with headaches or vomiting. The ocular red flags include limitation of abduction that does not improve with doll's head, vertical deviation larger than horizontal, and marked restriction on forced abduction. The action is MRI. These are the differentials, as you all know: infantile esotropia, type 1 DRS, refractive accommodative esotropia, sixth nerve palsy, nystagmus blockade syndrome, and sensory esotropia. The practical algorithm is, first, of course, a thorough history, cycloplegic refraction. The third step is to measure the angle. Fourth is to check the fixation behavior, check for abduction, and last, and definitely not the least, a fundus examination to rule out ocular tumors or other pathologies. The decision points: is there an accommodative element? Then, of course, go for glasses. If the angle is large, consider surgery. If there is amblyopia, aggressive patching first. If the angle is small, we may follow closely. The timing debate. What does the evidence say? Do we wait? If a child presents with esotropia, do we wait? So there was a landmark trial where early versus late infant strabismus surgery was done. It spanned across 58 clinics with 532 patients. The early surgery wing was from 6 to 24 months and the late surgery was from 32 to 60 months. As you can see here, the early surgery wing in blue, it showed a whopping 14% of children, they had long-term gross stereopsis compared to just 4% in the late surgery group. The neuroscience behind it. The critical period for binocular vision is 6 to 12 months. If there is normal alignment, then there is healthy cortical binocular neurons will develop. If there is strabismus, then it will lead to suppression and loss of cortical binocular neurons. Animal studies prove that 1 week of misalignment leads to irreversible changes. Human data corresponding is best stereopsis outcomes are achieved when aligned before 12 months of age. The take-home message: infantile esotropia is urgent. Earlier surgery leads to better stereopsis. Always rule out the accommodative component. Treat amblyopia aggressively. Set realistic expectations. Cosmesis and functional binocularity. Follow-ups are essential. And refer immediately. So remember this baby? She underwent surgery at 10 months of age, has housefly stereopsis at 3 years of age. She's able to do activities just like the other kids at her Anganwadi. She's able to play ball, play games that require stereopsis. These are my references. Thank you.
Thank you, Dr. Rohi, for that crisp talk on essential esotropia. So, the floor is open for any questions. 3 minutes. 3 more minutes. So, yes, infantile esotropia, as Dr. Ruhi has pointed out, if it is essential infantile esotropia, usually there is no accommodative component. But when there is even if it is a small hypermetropia, we do give a full correction to see whether it changes the angle. It's always better to give the full correction if there is a hypermetropia, even in that age group.
Congenital esotropia, large angle, definitely we have to do surgery. But small angles, like it's better to observe. And also one thing is long-term follow-up is needed. Sometimes they come with a large overcorrection later in life with a large exotropia. But the best part is the amblyopia can be prevented if you do it early. That is the best part. The rest you may have to deal with in the later part of the life. But still, large angle definitely have to go for an early surgery.
Okay, thank you. I'm happy that we had a reasonably good audience for this pediatric session. Thank you, each and everyone.